respiratory system, and then getting ventilation, respiration, and perfusion. And these three things are defined after that because they're really important and they're different. Ventilation, you move the air in and out of the lungs. I can do that with a machine, but there's no exchange of CO2 and oxygen. I'm just moving air in and out. When I do respiration, I'm actually having a gas exchange between the alveoli and the blood and the capillaries, okay? And then perfusion, that's the process by which you have oxygenated capillary blood pass through the body tissues. We're going to talk about this a little bit more when I talk about the alveoli and the blood supply, because if those alveoli aren't working or the blood supply aren't working, you're going to have a mismatch and it's a problem, all right? So I have some slides coming up on that. The scope of concept that we're looking at is adequate oxygenation. So on one side we have hypoxia, on the other side we have hypercapnia. So what does hypoxia look like? What do I expect to see with hypoxia? Low oxygen levels, increased respirations,
Tachycardia.
tachycardia.
You have cold extremities?
Might they be blue?
Yeah.
In the later stages, might I have blue around, you know, circummoral?
Mental status changes.
Ah, mental status changes, okay. What else? Anything else?
You
That's-
have low blood pressure, high respiration, high heart rate. That's
You
similar
might,
shock.
you'll have some pulmonary hypertension, but you might. Okay, so the things that we would notice is like if I had a pulse ox on it, where would it be if I were hypoxic? What would the rate be?
80. Below.
Below 90?
90.
Okay, so that's one of the things we need to know. 94 to 95 to 100% is normal, and that's what we're hoping for, and under 90% is low. So if you're on room air and I put a pulse ox on you, right, and you're below 90, and then I put oxygen on you, and you're still below 90, I'm not winning the battle. So that's what happens with the ARDS that we're going to talk about, okay? You're trying to do all these things to help, and usually it works like a charm, and it's not. The other side is hypercapnia. What are you going to see for hypercapnia? You've got too much what? Carbon dioxide, CO2. So what do they look like?
Drowsy. Sleepy.
Drowsy? What color am I?
Like
Flushed?
paler.
Flushed. They might be dizzy, they might be short of breath, they might have headaches, they might be disoriented. And you as the nurse spend the most time with them. You're the one that notices the difference in the patient's mentation. Like you can keep telling them, your name is Sally, you're in the hospital, it's June. They can repeat that back to you. But then one of the neurologists said to me, what you really want to do is ask them the purpose. So if you say, well, what are we doing here? And they go, we're at the races. Then I know they're not oriented, okay? Because that's not the purpose I'm here. There's no races in my hospital. But that sometimes helps you to figure out what's going on. And if you spend all the time with it, then it's up to you to tell the doctor, because sometimes that restlessness, confusion, it just starts out, if you know your patient and you know they're suddenly acting very unlike themselves, that sometimes is a big clue that there's something wrong. Does that make sense? You might also have dysrhythmias and seizures. Okay, so for lifespan risk factors, in infants you have aspiration, choking, rapid respiratory rate. Preemies have decreased surfactant. Why do I care about surfactant?
The lungs.
Keeps the alveoli open, and so when we do acute respiratory distress syndrome, there's going to be a problem with that, okay? So I need to know if that's a problem. Children, you could have a common cold, a childhood infection, exposure to secondhand smoke. So far, there's been nothing good about smoking that they've ever found. Maybe it relaxes you, but that's about it. Adults and elderly, they have a decreased lung compliance. So if I have a decreased lung compliance, how easy is it to get oxygen into you? It's very, very hard because they're stiff, okay? What if I have a decreased cardiac output? That would be a risk factor. And then elderly, they aspirate. So what happens when I aspirate? So gastric contents go into my lungs. Probably not helpful, not the right pH, but those are the things we see. The risk factors we have some non-modifiable risk factors, okay? Socioeconomic considerations, ethnicity considerations. You can't change those, where you are, who you are, that stays the same. Personal family history, that's gonna stay the same. Vitamin D deficiency, they're not talking about like, oh, I forgot to take my vitamin D, or I didn't get out in the sun today. They're talking about not being able to use the metabolites that vitamin D means, so that's a big problem. The modifiable ones that they can do is smoking, sedentary lifestyle, obesity. Does it kind of sound a lot like cardiac disease? They kind of fit together. All those things that they want us to stop doing. Abstain from immunizations. If I didn't get my child immunized, then they're going to be exposed to a lot more infections, and infections is one of the cause. Air pollution, high anxiety, stress, opioid use, exposure to allergens and environmental pollutants, exposure to certain recreational and occupational hazards, like firefighters breathing in smoke, excessive exposure to acetaminophen prenatally and in the first 2 years of life.
Ginny,
Yep.
when you said the vitamin D deficiency, can
Yeah.
you say that again? Like, what do you
So
mean?
it's not just like, oh, I forgot to take my vitamin D. It's like my body can't handle the metabolites, like
Oh,
the vitamin
okay.
D metabolites. So that's why it's non-modifiable, because if it wasn't, I'd just take my vitamin D and I
Right.
can modify it.
Okay.
You know, so. We also have the assessment. So the health history, you know that this hasn't changed much. It's the onset, location, duration, character, aggravating, alleviating factors, timing, problem-associated symptoms. These people are going to have something happen acutely to them, very suddenly, and they might be in for something else, and then have ARDS occur on top of it. I can't help it. Sometimes you come in with it by itself, sometimes you come in with it for something else. Say as you get your gallbladder taken out, and then you develop ARDS, okay? So the common symptoms you're going to see are dyspnea and tachypnea. We talked about that. Those are early signs. You're short of breath, your respiratory rate's up. You might see coughing and sputum production. You might see chest pain, especially if I take a deep breath. It might hurt more when I'm breathing than if I hold my breath. Wheezing, you might be able to hear it from across the room, or you might hear it with a stethoscope. And then hemoptysis, where I'm coughing up blood. And then we have psychosocial factors too, like quality of life, ability to carry out ADLs. How are things going? So if you have someone, I'm so tired, I can't do what I need to do. I can't feed my baby. I have to get up and dress myself and feed myself. Oh, I have to wash the clothes before I put them on. I have to go to the grocery store. I just can't do it. So it's not going to be very helpful for them. I can't run for the bus to get to work anymore. You know, it really impacts their life. So you want to see what's affecting them right now as this gets worse. And then critically ill patient assessment. We'll go over some of that. Okay, so one of the things we have to talk about is advanced airways. If I've put oxygen on you and I've done your cultures and I've tried to find out what organism is infecting you, and your PO2 is still terrible, and your oxygen saturations are still terrible, the next thing I might have to offer you is a breathing tube down the throat and mechanical ventilation, because nothing has progressed to made it better, right? I have no other choice. It has an extremely high mortality rate with it, more than 45%, maybe up to like 90%, okay? I also, if I'm on a ventilator for a long time, I might need a tracheostomy, because it pulls and it shifts and it causes inflammation and irritation, so I might eventually just put a tracheotomy in if it's been so long. But once I put you on a mechanical ventilator, to save your life, I have to worry about ventilator-associated pneumonia. Okay, do you remember we talked about VAP as one of the Plan, Do, Study, Act things? Do you remember that at all? No? Okay. I have some stuff on that.
It's one of those infections that the hospital owns if you get it, right?
I'm sorry, what?
If you get that, the hospital owns all the associated costs.
After 48 hours, they do. So the first 24 to 48 hours, they figure you might have aspirated at the scene or something, but once they put the vent on, you're right, they own it, and they don't want to reimburse you. So it's a big hot topic in the hospitals because it means your lifeblood, you know, do I get paid for this? When we talked about a VAP bundle, we also talked about, I could do a PICO. Remember what a PICO was? And I know people had trouble with it on the test, some of you. I know. So what does the P stand for in PICO?
Population.
Patient, problem, population. So if I wanted to do something about preventing VAP, looking at the components of the ventilator bundle. Who's my patient population?
People with vents.
People with ARDS on a vent, okay? So I is for what?
Intervention.
So when we looked at the things that you could have done, right? We said you do the VAP bundle all or nothing, and these are things that are supposed to help, and the IHA come out with them. I told you none of them really worked that well until they got to the oral care with the antiseptic solution every 2 hours. So I'm gonna say you elevate the head of the bed between 30 and 45 degrees so you don't aspirate. You do deep vein thrombosis prophylaxis so they don't develop that. You might do peptic ulcer disease prophylaxis, daily sedation vacation. If I put you on a vent, would you just like sit there nice and quietly? It's scary. So I'm gonna sedate you. I'm gonna make it more comfortable for you to be on this machine and to quiet you down and get you to breathe with the vent, because I don't want you bucking the vent, all right? And I'll talk about that in a little bit. I don't want you fighting the vent. When we started sedating them, we kind of had a heavy hand with them. And they said, what we really need to do is get these people off the vent as soon as possible. So let them have their pain medication. I'm not talking about pain medication. But sedation, we're gonna shut off and see if they can try and breathe on their own. You breathe through the breathing tube. It's like breathing through a straw. It's terrible. But you see if they can do it spontaneously on their own. And they're using their own muscles instead of the machine, okay? So the one thing we found after that that helped was the antiseptic solution with oral care every 2 to 4 hours. So if I did a PICO, what would my intervention be?
Oral care.
Huh?
Oral care.
Okay, but my intervention would probably be like the oral, yes, the oral care, that's what you said, I'm sorry, I didn't hear you.
Oh.
The antiseptic oral care would be, does it help or does it not help? So who would I compare it with?
People that didn't get that one.
People that didn't. And what would my outcomes be that I was looking for?
If they were sick or not sick or.
If they lived, if they were sicker, how well they did. Do I care if they get out of the ICU? Do I care if they get out of the hospital? Do I care for 1 month out if they're alive? Those kind of things. And then what about the time?
You have to put a time on it.
So you may or may not put a time on it, but I might want to time it in terms of, I only want things that are within the last 5 years, because knowledge gets old. I only want to look at coming out of the ICU, because that's my field. Or maybe I want a little bit more. So those things I can manipulate, but this would help me to look at what's out there in the literature and see how other people are doing, okay? Because before we did the oral care, everyone was like, I'm doing this, I'm doing this, I'm doing this, it's not getting better. And they were blogging, and they were all talking. And it was like, what is the matter? And then someone said, well, you know, we started this oral antiseptic care, and the companies all came out with mouth swab. It's got this on it, just use it, you'll love it, not hard to do. You can't get away from the dentist. Your mom tells you to brush your teeth, same thing. I had a patient at St. E's, and he said, he's a dentist, he goes, my mom's on a ventilator, why aren't you brushing her teeth? Why aren't you doing oral care on her? And at the time we were like, really? A toothbrush? Like we can swab, but a toothbrush? I don't think they can spit and swallow with a breathing tube in. But now everyone gets just a swab of that, and it makes a big difference.
I have a question.
Yep.
So, this is what we, as the nurse, would do if somebody's on a vent? Is that what you're saying?
Yeah, these were the interventions that I would expect a nurse to follow, and I would expect your hospital, and I expect your doctor to order. And what they're trying to do, what helps put it together is, this is what you would do to help prevent people from getting ventilator-associated pneumonia. Okay? It's one of the complications of putting you on a vent, but I have to put you on a vent to save your life.
So oral care would be the number one.
It was the number one. And these have been looked at by a number of groups, and they came to a consensus. And that's what you're looking at. Like, this seems to be the best practice around. Does that make sense? So that's what you can use PICO for. And I just wanted to remind you, because I know you had some questions on that, on the test. And we've mentioned it a few times, so I thought maybe we should talk about it a little bit. So, we have mechanical ventilation. We can put you on a non-invasive positive pressure ventilation, BiPAP or CPAP. You know people who have sleep apnea and they snore and they get those machines? I have pictures coming up with them so you can see what they look like. They have the face mask. They like to bring them into the hospital. They love their own mask. They don't want to try someone else's. This one works good. They just have it checked out by biomedical engineering. So that's one of the things I can do. Or I can put you on mechanical ventilator. And you'll see this one right here, okay? The endotracheal tubes there is circuitous tubing. It's a circle, comes from the vent to the patient and back again. Why do I care about that? Well, it has to help me with the alarms. You don't have to learn a lot about vents, but you need to know when 3 alarms go off, my patient's in trouble, and I need to do something, okay? Does that make sense?
What do you mean by
Alarms
3
are
alarms?
warning. I'm gonna tell you which 3. Those 3 up there.
You mean at the same time or like one after
One
another? Okay.
one at a time, hopefully. But you'll hear, you know, the ding, 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 and it's like, a lot of times they ask you questions about that. So this alarm goes off, what does it mean? So if I had a low pressure alarm go off, right? I showed you the tubing that comes out from the vent, goes to the patient, comes back again. It actually knows how many mLs it sent out and how much came back. If I had a low alarm, I didn't get it all back. So where did it go? Probably something disconnected. So I'm thinking that there's an air leak someplace, and that's what I'd be checking for. So a low pressure alarm means I didn't get back everything I sent out. Where's the leak? Where's the disconnection? Did the tubing pop off? And you know, patients in the OR, they stay nice and still. You put in the tube, everything's fine. In real life, you turn over once, those tubes don't come around, and they certainly don't, if you flip over one more time, they don't come with you. So there's a lot of stress and pulling on it and stuff. So it's not unusual that, you know, something might get pulled up if they're really rough and you don't remember where you are and you just want to turn and get rid of it.
So, the low pressure means disconnection or leak.
Yes. So I don't get back the same amount that I put into the vent, does not come back to the machine, and so it alarms to let you know something happened. So you want to check for a leak or a disconnect. Did the tubing come apart? Did the patient pop off the vent? Okay? The second type of alarm you have is a high pressure alarm. You get this when you're trying to put air into the lungs and they bite on the tube. If you bite on the tube, the air can't get through, right? If I bite on that plastic tube, it's squished. So it's alarming. So it could be that I'm biting on the tube, but it also could be an obstruction or a kink. That plastic tubing, maybe it just kinked. It goes around, you know how things kink?
Yeah.
If it's kinked like that, I'm not gonna get the air in. So it's not gonna keep doing too much pressure. I can't blow up your lungs, right? I have to stop at some point and alarm and say, there's something wrong, it's too much, there's a high pressure alarm going on. You take your patient off, you ambu them, call respiratory, they come check out the vent.
So you would take them off?
Well, they're not getting the air. So if he's not getting the air because there's a kink in it, if I ambu him, and you've ambued in CPR and BLS, right? If I ambu you, you're getting air in. I can make sure he's not biting it. I can make sure he's getting air in. But I don't know where the leak is, and I can only do one thing at a time, take care of my patient.
Okay.
Then respiratory comes and takes a look at the vent, and it's like, what is it? Did you find a disconnect? Did you find something? And they can look for me.
So if there's no air, we take them off the machine, ambu them, and then sound
If you
the
hear the high pressure alarm, all right? Does that make sense? And mostly they want to know if you know what the alarms mean. So low pressure, I disconnected, there's an air leak. High pressure, I can't get the air in. So there's got to be an obstruction or kinking or he's biting on the tube, okay? The last one is apnea, and I added on that, it's, I have no chest movement or no breathing. Is that good? Okay, so if he does that and he's supposed to be on a vent, I don't know what's wrong, but I'm gonna take him and ambu him with the ambu bag so that he gets air and have someone check the machine out. So all 3 things are bad. Did I lose you?
Can you say that again?
Okay, so if there's apnea, there's no breathing, there's something wrong with the machine, I don't know what. I'm gonna take him off the machine, leaving his tube in, ambu him, give him the oxygen he needs, and have someone else look at the machine and fix it.
Oh.
Okay? Because my prime thing all the time is my patient. Does that make sense?
So for both low, I'm sorry, for both low and
I'm
the
gonna ambu them. If there's something wrong with the machine,
apnea, okay.
I'm gonna just breathe for
Yeah,
them, and I
so
know
for
they're
both.
getting breath, and their pulse ox is okay, and someone can fix the machine for me. The cause of it will differ. If it's a low pressure alarm, it's probably a disconnect or a leak. Okay?
So all three you want to ambu them?
Yes,
Okay.
exactly.
All
Your,
three?
your answer to all three of them would be to ambu them.
Okay.
But also to have someone troubleshoot.
Okay.
Does
So
it-
all three is ambu and troubleshoot?
Yes, because there's something wrong.
Okay.
I don't know what it is, and my first priority is gonna be to get my patient air, and then let them fix the machine. But I kinda know, like, maybe he's just biting the tube, and I just have to put in an oral airway. Maybe there's a kink, or maybe I need new tubing. Sometimes you have defective tubing, or they have to replace it.
So for any of these, we'll call them an ambu.
But the alarms they're gonna ask you are usually like, low pressure alarm, what causes it?
Air leak,
Okay, high pressure alarm, what causes it?
obstruction,
Obstruction. And what's apnea alarm?
no chest movement, so it's
Okay.
not detecting it.
Yep,
So, I'm just thinking of a scenario. So if you said, if a question like that came out, says, what would you do first?
Why not?
Would you just go straight to checking the tanks, then you do it with bad if that's what comes next, right? Or no? I just want to double check.
Would you ambu them first or make them breathe?
I would,
Or would you check the tanks?
yeah. I would wanna ambu them first to get, air into my patient so he's alive.
Okay.
And then respiratory can be called, someone else can be called to like look at it.
Okay.
Because if I stop to look at the machine and he's not getting air, the whole time I'm playing with it, he's not getting air.
All right.
He's not happy. Does that sort of make sense?
Yes.
Okay, so we're not gonna do a whole lot of mechanical vent, that's probably one of the things they might ask, that you might see. This is the Bipap machine, the one that I talked about when they come in with their own mask, Bipap or CPAP, and they send it up. It's not invasive. You don't have to put a tube down their throat. It just fits on their face. Do you think you could eat with one of those?
No.
Do you think if you had all that stuff going down and you had a full stomach, you might vomit?
Yeah.
Okay. So those are things they usually look at too.
I have a question.
Yeah.
How long can you leave them on the BiPAP for?
Depends on how long they need it, truthfully. Some patients can't come off of it, tolerate it at all. Some people, if it's just for, snoring, sleep apnea, they just use it at night, and once they're awake, they're all right. But other people, they'll use it as a treatment that have really bad lung disease. And they'll be like, oh, I don't want to intubate you yet, I'll just try this. If I take you off and your O2 stats plummet, that's not good. But if I leave you on and you're good, then I'm gonna have to wait, give you corticosteroids, see what else I can fix. You need antibiotics, so you're having an infection. Then you might get better and then I can take it off. Does that make sense? And I'm sorry to say two things, but I'm using it for two different reasons.
No, it does, because I've had people with it, and like there's things are always different. Like I had one lady who was with it, she had it overnight, and I guess her CO2 was so high, like she really went home and died. And then
Yep.
I had another one who had to be on a 1-to-1 because I guess if they like vomited or something, they weren't capable enough to take it off themselves. So I'm like,
Exactly, exactly. So those are things that you have to think about. So usually with ARDS, I don't usually see them go to the BiPAP, I usually see them go to the breathing tube
okay.
or the trach, if, eventually. These are some of the things we were looking at, and we liked this picture so you could see some of this. Do you see that strap holding it on? That's a commercially prepared securing device. That means it holds the tube in place, so when you put it in, you blow up the balloon, and that also helps to keep it in place. And if you look on here, you can't really see it, but there are little lines on there, so I can tell what the lip line is. It should stay there. But if I roll over in my sleep, do you think it might pull out? Or if you're suctioning really good and hard, do you think I might pull it in? So I need to know where the lip line is. The other thing that we have now is, see this plastic covering the suction catheter? That was one of the things they thought, well, maybe this will prevent pneumonia too, because we'll keep the catheter, not a suction tube hanging on the bedside, right? But we'll actually keep it in plastic, use it when we need it, pull it out, and change it, whatever they say, every 24 hours or whatever their program is. That might help too. Okay? So for ARDS, that's going to be our exemplar, acute respiratory distress system. It comes in extremely quick. Yep.
Are we gonna answer a little bit between a BiPAP and CPAP? Because we.
No.
Okay, so I know, but I have them at work, like, I don't understand what the difference between, because I think the CPAP's what we have and the BiPAP's what the patient kind of brings in from home, and I have no idea, no one's what I
And
need to.
someone uses the term interchangeably even though they're not. So you can also have a CPAP, which is constant positive airway pressure on your vent, and the BiPAP is just 2 levels to keep, and all you're trying to do is keep the alveoli open. And we're gonna talk about
So they
alveoli
both do the
next.
same exact thing?
They both do the same thing, but one might be on a vent and one might be you need a mask. Okay? So one would be on the mechanical ventilator and one would be a separate machine I'd plug in. Is that, but we're not gonna ask you that, honest.
Alright.
We're not gonna ask you that. So acute respiratory distress syndrome, why were they really interested in this, right? It comes on really suddenly. It has an extremely high mortality rate. And people noticed it was different. There were a lot of things that can cause it. So one of the things I need to look at is risk factors. Septicemia, critical illness, alcoholism, abuse. Those can be risk factors, but you can also have many causes. The patient we're gonna do in the concept map, he came in to have his gallbladder done, and then he ended up with acute respiratory distress syndrome. So it happens suddenly after some kind of an insult, like aspiration, drug ingestion and overdose, hematologic disorders, prolonged inhalation of high concentrations of oxygen. Do I want to keep my oxygen up high? Do I do that with babies?
No.
Okay, so my goal is to get it like, where would I like my O2? PO2?
2.
80 to 100. I would like it up to almost there. I'd be happy with 60, maybe. But if that's the best I can get on the person, right? And what about the pulse ox? What's a good pulse ox number? 94, 95, 100. What if it's lower? I'm gonna try and use as much oxygen therapy as I can to improve it, okay? Until the point where I'm gonna say, I'm gonna have to give up and intubate someone. Once I get him on a ventilator, it's the same thing. I'm gonna try and use the lowest amount of oxygen I can and still keep him in a good range, okay? Inhaling smoke is not good, so if I'm a firefighter and I'm at a fire and I inhale a lot of smoke, I might have problems. Corrosive substances like chemicals that you breathe in, localized infections, metabolic disorders, obesity, pancreatitis, low protein in the blood, those things might affect it. Shock, trauma, major surgery, came in from my gallbladder, fat or air embolism, if I broke a bone and a fat embolus comes out, like I broke a hip, and sepsis. Those things all cause it. So there's a big array of people that have it, and that's why it's so important to like notice when your patient suddenly is increasing his breathing and he's short of breath. How am I going to diagnose it? Well, I've got BNP levels, the plasma brain natriuretic peptide. Do you remember what we used those for when we talked about cardiac? Heart failure? So it's high or low in a cardiac patient? High. So with heart failure, it's high. So if I have acute respiratory distress syndrome, am I thinking it's high or low? Low. Good. So I'm saying, oh, it's non-cardiac, it's not heart failure that's causing the problem. I could also have an echocardiogram done to see how the heart's functioning. The heart's fine, it must be the lungs. Pulmonary artery catheterization, you don't have to know about that, but the pulmonary system is only like 30 millimeters of mercury. What's your blood pressure? Normal? Anybody? Okay, so that's much higher. So it's really hard for that pulmonary system to work against the really high one. So why do I care about that? If I stand up, the dependent areas, the perfusion's gonna go down here. If I lie down, the perfusion's gonna go here. Well, what if I have alveoli in the rest of the places that's not getting perfused? The only way I can do that is by proning you or flipping you. Okay, so we're gonna talk about that too. But those are things that are important. Chest x-ray.
So the BNP and the echo are just like rule out any like
Rule out the
problem.
heart. Yeah, because I don't know if you can't breathe because you're in heart failure or if it's respiratory. Because remember, this happened sudden, and you might have come in for a gallbladder surgery, and I'm like, what? So I'm looking very closely at my patients when they develop this. I'm thinking, ooh. One of the things that helps is acute respiratory failure is now called acute lung injury. Acute respiratory distress syndrome is at the highest end of that. It's the most severe, okay? So how do I know that? I might have trouble figuring that out, right? I just want to switch to this. I gave you some of this. We can't get away from the perfusion. We had circulatory perfusion. So when you're looking at the alveoli, and I don't draw well, so here's a picture of the alveoli. Here's a nice little alveoli, the blood's coming by, see it's kind of blue, it picks up oxygen, it exchanges, it gets rid of the carbon dioxide. Excellent, I'm happy. Here's one that's not so good. See where the yellow thing is? There's an obstruction, there's something doing it. That alveoli is not good, it's not performing. So I have blood coming by, it's fine. I don't have the ventilation, I don't have the oxygen going into the capillaries. I need both of those. I am very greedy, I want both, okay? Does that make sense? If you have too little oxygen reaching the alveoli, you could have pneumonia, you could have bronchospasm. If you had too little blood reaching the alveoli, you might have heart failure or pulmonary embolism that would affect the circulation. And then you end up with hypoxemia, okay? Because I can't get the oxygen into the blood where I need it. One of the things that we look at, and you guys were saying that, is the chest x-ray is the hallmark. I just want you to look at this. You're not responsible for it, but it's really striking. See on the left, what color is that chest x-ray? Kind of black with some gray in it, okay? Look at the one on the right. What color is that one? Really white? Whited out? Okay, so people looked at that and they're like, I don't know what's going on. They started looking at it in 1991. But they also noticed it in the Vietnam War, that young fellows that were exercising, eating right, really young, like 19, had trauma, and all of a sudden they had a whited out chest x-ray. So it's called shock lung or acute respiratory distress syndrome. This is the hallmark. It looks like a snowstorm, it looks like a blizzard when all you can see is the snow in front of your face. It's so whited out, I can't really tell like where the heart is, where in the other one, I can see the shape of the heart, okay? You don't have to read these. The radiologist does. You can pull them up on your computer at work at the hospital. But this is just showing you the difference, and this is what struck them. It's like this is the hallmark sign. If my guy's not doing so well and I do a chest x-ray every day in the hospital and, oh, find this, then I know what's going on. I have a good sense. All right, so. So I find clinical manifestations, right? This means what kind of signs and symptoms do I see that fit with this? Bilateral infiltrates by x-ray. Now you're thinking, okay, there's alveoli there. They're infiltrated with fluid. I can see the whiteout on the x-ray. What are his lungs gonna sound like? Is there that much fluid in them? Crackles, arouse, and then maybe wheezes as it progresses. Severe hypoxia. Well, we already said that. I can't get the pulse ox up. His O2 sats, they're not coming up. If I do an ABG or a VBG, the PO2 is not good. And I have poor alveolar perfusion, and that's what we talked about, the blood running by the alveoli. It's not working. I might also see intercostal retractions. Have you ever seen the indents on the ribs when they're breathing? Because they're working so hard. On skinny people, you can see that.
Isn't it the higher it is, the more severe it is?
The higher what is it?
The,
Retraction.
yeah,
Oh, I don't know. I don't like seeing any kind of retractions, but I would think that the deeper they went in, that maybe I was trying really hard and having a difficult time. I think I tend to see those and kind of go more by my pulse ox and maybe the ABG, because then I could say, oh, he's not oxygenating enough. So I want to switch back to this. We have to talk about the pathophysiology, right? So one of the things that you guys are always asking me about is timing. So I went back to look at the signs and symptoms of ARDS, and in terms of timing. This is on the little one that I gave you. I posted the handout one. Just look at it for now. Don't worry about it. You have
It's
it.
not on there.
It should be. I put.
I just found it.
It's under a handout. And
It's not
Yeah.
on there. You just added that.
No, I don't have it.
you don't have it. All right. Well, I will add it for you. I thought I did.
No, it's not on the one you added.
It's that one you have.
Yeah. the
Okay,
next slide.
so I added this, and I was just looking at it in terms of time. We talked about it occurring suddenly, within 24 to 48 hours after a precipitating event, the cause, right? Usually, what do you see? Increased respiratory rate and dyspnea, those are your early signs, okay? Your body starts to compensate. I can't get enough oxygen in, I think I'm gonna breathe faster, okay? Does that make sense? The later signs we talked about was a cyanosis and pallor. I'm blue, my fingertips are blue, around my mouth is blue. And then breath sounds, you just told me, crackles, maybe up to rhonchi and wheezes, right? And the chest x-ray finding. You have that all in your notes, maybe in different words, but it's there, okay? We wanted to look at the pathophysiology of it, and maybe this will help you understand it a little bit better. So it suddenly occurs with an acute lung injury, and the alveoli is where the gas are exchanged. They get inflamed because there's something going on. They send in cytokines. They start, trying to get rid of the infection. They cause more problem than they're worse at this point, right? If you get a cut, do you not see like swelling and stuff going on around there while it heals? Well, if I take more space to go between the blood and the alveoli, I'm not going to get as much oxygen across. So at first I'd say, oh, inflammation and cytokines, that's good. They should be in there. The macrophage should be in there eating up the bacteria, and that's good. After a while, you get too much of them, and they're interfering, okay? And then the alveoli themselves, they have increased permeability, and they're leaking fluids, and there's fluids all over. You have protein levels that build up, and they pull fluid into the alveoli. So again, I'm having trouble breathing because I got to get the oxygen through all this water, this fluid. And I have a reduced amount of surfactant, which keeps the alveoli open, and I like, but I don't have as much surfactant as I usually do, so those things can wither. And then the hypoxemia, even increasing my oxygen delivered and adding PEEP, the positive end expiratory pressure, doesn't improve. I don't get better pulse oxes, I don't get better ABGs. I might have some pulmonary hypertension, and I might have decreased pulmonary compliance or very stiff lungs, okay? So you've seen these on all of the books, we have them, and I think this is the best way to explain it. In A, you have a normal alveoli, right? And look what's going by it. The bloodstream's going by it, it's blue, now it's red, it's dropped off what it needed, it exchanged. I'm happy, all right? The opposite thing that can happen is a silent unit. I have no blood going by, I have no oxygen in there. That would be like a cardiopulmonary arrest. No blood pressure, no heart rate, no nothing. It's not working at all, okay? Then you have two things left, okay? If you have perfusion without ventilation, then, oh, I have the blood going by, but look at my alveoli, it's not working. So I have alveolar collapse, fluid overload, pneumonia, and then ARDS. So that's the picture of ARDS. My alveoli aren't working, I can have all the blood rushing by in the world, but if I can't get the oxygen over to it, it doesn't help. The fourth thing that can happen is, in this one I have a nice alveoli, it's got all the oxygen in it, but the blood running by it is not good. So it's obstructed, there's maybe a tumor there, or there's a pulmonary embolus, or there's something so that it can't pick up and exchange the oxygen. So the thing we're looking at is alveoli that aren't working. Does that make sense for ARDS? Did I lose you? No? Okay.
Yeah.
Who said yes? Can I help at all? What's the matter? What do you think? You know the alveoli, they're at the end of the lungs, they have all that oxygen in it.
Mm-hmm.
They've got to get their oxygen out, pick up the CO2 and get rid of that, and it's got to be in the capillaries where it's done. The blood's got to pick it up. It's sort of like you go to a train and you're waiting and it just runs by you. There's no connection, there's no exchange of people, there's no exchange, it's not good. Or a Ferris wheel that just keeps going around and around. It never stops and lets off people and lets on new people.
Mm-hmm.
So you can't do the exchanges you need to stay alive. You can't get more oxygen and get more CO2.
Now, is that because of the fluid that causes that?
Yes. So the fluid and all the insult that's going on in there and the inflammation going in to treat it, that disrupts the alveoli.
So B, there's like good airflow, there's just no blood flow.
I get it.
Yeah.
Okay.
Yeah, so if it was disrupted for some reason, I could have all the wonderful air in the world, but if I don't have the vessels to carry it, I'm out of luck. So C is what we see with the
So there's no exchange.
ARDS.
And that we say like pneumonia, atelectasis, is that all the same?
Yeah, so
picture?
atelectasis is collapsed alveoli. Pneumonia, you're filled up with that fluid, they're coughing up all that stuff. They're not working right. And that's why you're having so much trouble. That's why I can't
You're
oxygenate you.
sending more deoxygenated blood back to the heart. instead of
Exactly,
oxygenated
exactly.
blood.
It goes out to the body and you haven't exchanged anything. So you're in trouble. I'm sorry I'm flicking back and forth, but sometimes I think it's easier to show you a picture and you maybe understand what we're gonna talk about and, you know, other things. So when you think about this, you're gonna think about, I have to breathe really quickly, I'm short of breath, maybe blue near the end. My x-ray shows 2 lungs, bilateral, infiltrates, fluid. I hear rales and then rhonchi. It'll make you think of that. Trust me. She's laughing, I know. So management, we talked a little bit about this. If it's bad enough, the doctor's gonna order an endotracheal intubation. When he does that, anesthesia comes along. They suction out your patient, they put in the tube, they secure the tube, and then what do I as the nurse do? Auscultate. What am I looking for?
Where the tube is going.
So am I looking, what do I wanna hear?
Lung sounds,
Breath
breath
sounds.
sounds.
What if I don't hear breath sounds?
Something's wrong.
It probably went in the stomach. What if I only hear breath sounds on the right? Probably went into the right main stem. So when you break off your right and left main stem, the right one is bigger and wider. And if you're gonna slip a tube in there, it's gonna go in that one because it's bigger, and this one's smaller. All right, and I'm gonna pull it back a little bit if I only hear it. But the nurse is usually, is my patient getting air? Do I hear breath sounds? Are they on both sides? I need to check that because, yeah, I'm gonna order an x-ray and see what's going on, but I'll know much quicker if I don't hear anything. And it's really hard to get that tube into the lungs. It's not unusual for it to go into the stomach instead, okay? And they need to help with that because they're like, oh, I just did this. Whenever you're going to do like suctioning or intubation, do you always pre-oxygenate?
Yeah.
Yes.
So they usually have suctioned the guy, pre-oxygenate, and then do it, and usually they hold their breath. So if I can't breathe the whole time he's putting in that tube, patient can't breathe. If I'm like, excuse me, do you think you could stop so I could ambu him a little bit because it's taking so long? But people are like, oh no, I'm almost done, wait, almost, I think I got, oh, I can see this. Sometimes you just have to say, excuse me, because like if I can't breathe anymore, he can't, and just let me give him a few breaths, then go back to doing it. And they hate to do that because, you know, you're almost there, you almost got it in, everyone's looking at you. But it's one of the things you want to do for your patient. P, positive end expiratory pressure. You really don't need to know a lot about that, but it's pressure that keeps the alveoli open, okay? And if they stay open and not collapsed, I've recruited more. So ones that were, you know, collapsed and not working, they're now puffed out. So that's a good thing. So there's more than 300 million of them, but whatever ones aren't working, if I can recruit more, and I'm recruiting them just like you want to go into the military and get recruitment, come work for me, I'm getting them back in. Okay, so that's called about recruitment of alveoli.
So what does the
Yep.
acronym stand for?
The ARDS or the P, positive end expiratory pressure. And you dial it in on a mechanical ventilator, so you really don't need to know a whole lot about it except for it's used to keep the fluid out. You'll see if it's working properly, your PO2s are gonna go up and your O2 saturations are gonna go up because you've got them open and you've got more air exchange happening. It's a good thing. Okay, so the other thing is circulatory support. I have to check his vital signs and his blood pressure. I may need to support them. He might be a little bit lower on a vent. I might need to use medicine. Yep.
You said if the PEEP is working, the PaO2 is gonna go up and what else?
And the pulse oximetry, oxygen saturation. And that's something I can see if I have, you know, the pulse ox on him, on his finger. That's your hint. Think about that. I need to make sure they have adequate fluid volume because they're sick, they have a fever, they've been diaphoretic, I may need to replace fluids. Nutritional support is important. So if I have a breathing tube going down my throat, am I eating? No. Docs forget about that. You have to remind them. And then the dietitians help us figure out what to do. You can do tube feedings, you can do parenteral feedings, but you gotta do something to keep up the nutrition, okay? So that's something we have to fight for the patient. And then prone positioning is something we do. Because we're trying to recruit alveoli, and I'm trying to change which alveoli are getting open and getting perfused, I want to show you a picture of this because I think it'll make more sense if you see this. So there's different ways to turn someone. I can turn them on their side like in this bed, right? Or actually that man is prone. He's not supine, he's not lying on his back, he's lying on his face. And he's kind of like swimming because that's like a comfortable position for certain people. But when I lie down, if all the perfusion is here, if I lie forward, all the perfusion is here, I'm getting a whole different area to come back and open up the alveoli in that I couldn't get before. So you don't do this lightly. I usually just turn him and position him, but if the oxygen's not getting better and the PO2 looks worse and the pulse ox is worse and he's on a vent, I might try this. And they'll order it for like 18 or 20 hours a day, okay? It has some downsides, like you see the guy with the face in the, if you're on your face, you're gonna get facial swelling. You know how the beauty magazines say, lie down in bed, sleep on your back, saves your face? This one you could end up with bad swelling, but it's for a good purpose, you can now breathe. But you have to tell the family that. The other thing is, see the picture in the bottom? There's the vent, right? There's the tubing, the blue and white tubing going across, and he's lying face down, or she, I can't tell. Let's see. I just forgot what I was going to tell you. So 18 or 20 hours, he's lying down. I can't do this by myself. I'm going to have respiratory come, and I'm going to say, will you handle the breathing tube and the ventilator? And we're going to have to flip him and make sure all the lines don't get messed up, and then he's going to be there. Now, am I just going to lie there while that's done? Or am I going to be extremely nervous? I'm already anxious. I can't breathe. And you're doing what to me? I don't want to be face down. So I'm going to perhaps paralyze you temporarily with chemical paralyzers, because I need you to help me allow the lungs to accept the air that I'm giving because they're so stiff. This is going to relax the lungs. What can I use for that? You heard? Yeah. Anesthesia type drugs like pancurarium, atracurium, norcuron, they paralyze you. So you got a patient now in bed, he's paralyzed, he can't move, you got a breathing tube in, he can't talk to you. Do you think he's scared?
Mm-hmm.
They're like scared to death. So you have to make sure that you give them sedation to calm down and relax them. And you have to give them pain medicine so that they know. And then I've had more families come out and they go, he's never going to walk again. I'm like, what? Well, they're going to paralyze him. It's a temporary chemically induced paralysis. So when you're doing education, you want to make sure they understand that. Like, it's not meant for totally he can't move and now he's paraplegic. No.
Breathing, but he's never gonna walk again.
Yeah. But what we're going to do is if he relaxes and if we give him these drugs, I can now get the oxygen in, his lungs aren't so stiff, and I can maybe save his life. And I'll know as this is happening, I'm not going to allow it too long, it's going to be a short period of time. I'm going to be able to check my pulse ox and his respiratory rate and stuff and see how things are going and if it improves, and I'll know.
So it's just like can paralyze them for 18 to 24 hours.
Yeah, because if I want you to stay on your face, it's really hard, so it's better off if you can't move and you go to sleep and you relax.
Okay.
And I explain to you what's going on. Now, I also have to talk to you because I can stool, but I can't blink my eyes when you paralyze me. So I'll have my eyes, put the ointment in, put a gauze on it, tape it shut. Now I can't see, I can't talk to you because that's in. I can't move. I am petrified. So the lifeline is the nurse, the person that comes and talks to them. I know you're alive, I'm gonna be here with you all day, all the alarms are set, you're wired for sound, the nurse's station knows. You have to sort of let them know what's happening. Most of those drugs last about an hour. So if we give it in a continuous infusion, they may not come up. If we give it push and then come back and give push, they lighten up a bit. So when they lighten up a bit, you just talk to them again and explain to them what's going on. They said the worst time is if they don't hear your voice and when shifts change. So Susie Q took care of me, and I know she knows I'm alive. Everyone else, how do I know they're alive? I can hear those doctors talking. Are they talking about me? I don't know what's going on. Does the next team know? Am I here alive? Did you guys forget I'm here? So if all that's going on, you want to sedate them, you want to give them pain medicine, and just keep reassuring them that you're there with them. Yep.
For the Rocorium, the paralyzation
Yep.
drugs, are those ones,
Neuromuscular
drugs we
blocking
should know?
agents.
Are those important drugs we should know as well?
You should know the class, the neuromuscular blocking agents, yeah. And she wrote them down there.
So essentially, they're like trapped in their own body.
Exactly. And they really rely on you, because that's why you need to give them pain medicine and sedation. You don't want to skip on the sedation.
It's just like, is there like a maximum time, like how many days how many days?
They're
Can
gonna
they-
try that
until
for
they're-
18 or 24 hours. If he
That's
does
it.
better, they're gonna flip him back. If he doesn't,
Then another
they
day?
have to decide whether they're gonna do it longer or
Okay.
give up. Okay?
Okay.
So, it depends, but I don't want him to be paralyzed for more than a
Right.
short period of time.
Okay.
No, but you wouldn't try to, what if that cause like pressure stuff, you know, you're.
I know. So did you see that special thing on his face? There were pressure relieving devices. See that white thing right up here?
Oh, okay,
See
yeah.
this? That's made so you can put your face in and you don't get pressure. Then they have things that you put underneath you that keep you off the bed and without getting pressure sores and stuff. So that's why it's a big, long, involved thing. Everyone keeps looking at different kind of things, you know.
So they
what-
like insert a Foley in them and
Yes,
stuff? Okay.
Foley, vented, everything, so you don't have to do anything. Yep.
So would you do prone position and like the drugs to help them at the same time?
Yes, because to stay prone, I need to knock you out. And then the lungs relax and I can get oxygen in there. And I know that you're comfortable and we can do this for a period of time. Okay? The other two pictures I have here are, this is another bed that turns you, okay? And this is a rotoprone bed that has all these arms that go around you. It looks horrible, but you put them in, you do this, and it just whoops, rotates you, and you stay. It's not bad. They said, you know, there's a place, your feet hang off here, you explain what's going on. Just so you can see. Well, it saved people's lives. I've seen people that they were like gonna give up on, and they decided to try that, and we were able to get them back, get their pulse ox up, get their oxygen up, and they lived. So it wasn't probably his first choice either, but it was to live. He wanted to live. Yep.
Excuse me. So you said you would do this, and you continue to do this if they're getting better, or you wean them off when they're getting better?
If they get better, I would wean them off. You know? And you trial it. The docs will go, try this for a while, see if it works. If it works, okay. If it doesn't, we decide, do we go a little bit longer, or
What is the time
do we stay
period that
comfortable?
they use to see if it's
18 to 20 hours.
And then to see.
And then we'll flip them back and we'll see what happens when we flip them back. And can we get everything, can we get more alveoli working? Because this is like the severe end. You know, this is like not just acute lung injury. The mortality rate's really high, and they found these things help. Yep.
Or something like this, would this be like diagnosed like up in a unit by the time they figure this
A
out?
lot of
Maybe?
patients come in and they start on the floor. So if I'm on the floor and I had my gallbladder,
Oh, okay.
oh, and then all of a sudden I have a fever and I can't breathe and my respiratory rate's going up. And then if I haven't talked to anybody and you come in and you're like, oh, my fingers are blue. And you're like, oh, what's the matter? And then they do the chest x-ray and they find this. So it could be in the ICU, but it could be something else. You could be coming in, oh, fractured hip. I broke my hip and then I have a fat embolism, you know? I wish I could say it only happens in the ICU, but it doesn't. It like, you might see it anywhere along. Or you might come in with like, I think I have terrible pneumonia. And then you're looking at them and they're kind of decompensating and you're like, oh, okay. So it is things that you want to look at because you're going to see the more subtle end, but sometimes it's easier when you see the higher spectrum because you're like, okay, this is really bad, this one's not so
But
bad.
sometimes the ARDS can be treated without the ventilator.
Yes.
Sometimes
If I put oxygen on you and your pulse ox came up and your PO2s came up, fine. Maybe 100% non-rebreather would work fine, and I would do that, that would be fine. But then, on some people it doesn't work. So it's on those that it doesn't work, you're not improving them. What are you gonna do for them next? Proning is something they ask questions about. One of the things, if you like alliteration and you like the 5 Ps, and you think about what kind of supportive therapy do you do for ARDS, I just included this. Perfusion, because we can't get away from it. I need the blood to go by and perfuse. Positioning or proning, okay, and you see that again there. Protective lung ventilation. I put you on a vent, I added PEEP, I paralyzed you so that I can get air in because your lungs are stiff, but I'm protecting you. And then what's this protocol weaning? This is my favorite. This is the VAT bundle. Okay, so how do I get you to not come down with pneumonia after I put you on the mechanical ventilator? So that's protocol weaning. And those would be the things we told you, like, oh, I turn them, I suction them, I do mouth care, I prevent Dvt Prophylaxis. How do I do that? Anticoagulants, what else? Compression boots, maybe embolotic stockings, range of motion, so that I move you. And if I move you, does that help? I am really making it easier for you, so you don't have to expend so much energy. Those things you know. Prophylactically, if they give you GI drugs, like protonics or some of the H2 blockers, they feel that it maybe changes the pH, and so if you aspirate, it won't damage the lungs as much. But then there are people that say, if you change the pH, then you make them more prone to get an infection because the lower pH is saving you from getting infections. So that's kind of in there with a question mark. And we talked about complications. So that's basically everything we're going to do. And it's all evidence-based. I just have to bring this back to that other class we had. The reason I got all these is evidence-based, okay? You can't get away from that. I know you'd like to. So I'll get back to, I gave you neuromuscular blockade, rocuronium, vecuronium, pancuronium, atracurium, one of those. I gave you sedatives, lorazepam, midazolam. Sounds like, what kind of drugs? Benzos? Okay. Then I give you dexmedetomidine, which is also called Precedex. And the nice thing about this is it's an IV drug. It goes in a continuous infusion. I can give it to someone that's on a vent. I can use it for up to 24 hours, and I can take the breathing tube out. It helps sedate you, so it gets rid of your anxiety, but you can stay breathing on your own. It has some properties that it gets rid of pain, and so I might use that as a sedative. Or I might use propofol, which we usually use as an anesthetic drug, to sedate you. If I have all these sedations going on, I don't want them to stay forever. So that's the sedation vacation. And it's a nice little catchy phrase. At some time I'd like to turn these off and see how you do, and see if you can breathe. So as soon as possible, we can get that tube out and not make you have a trach. I also want to give you pain medicine, so morphine, fentanyl, that'll be fine. Give you opioids, IV, they work quickly. And then nitric oxide, it's a vasodilator. Some hospitals use it, some hospitals don't. It might help. So we also, do you need an arterial blood gas review? People told me in a day they'd already had this. Do you want a review of this? Okay. So the normal range for arterial blood gases is 735 to 745. The PaCO2 is 35 to 45. Your PO2 is 80 to 100. What's your bicarb level? The
22 to 26.
22 to 26. So I put in there to remind you about respiratory opposite, metabolic equal. So when you look at this, if I have acidosis, metabolic acidosis, oh, what's abnormal is my bicarb, what's abnormal is my pH. With metabolic alkalosis, oh, I have too much bicarb and my pH has gone up. Respiratory acidosis, I've got extremely high amount of CO2, but my pH has now gone down to reflect it because it's opposite. And with respiratory alkalosis, my CO2 is below 35 and my pH has gone up because I don't have as much of it.
So it's the CO2 in the bicarb that will tell you whether it's respiratory or metabolic.
And the CO2 is respiratory and the bicarb is metabolic. So if you take a, I have one of these little, do you remember the tic-tac-toe thing that you did before? Okay, I put one in here just to help you out. So when you look at this, the 735 acidotic, 735 to 45 normal, alkalotic more than 745. So my pH is 7.47, so it goes under the alkalotic setting, right? Okay, so my pH is alkalotic. Then I look at my PaCO2, it's 34. Well, that's gonna go into alkalosis, right? And then I got the bicarb, it's 21. So this is a respiratory alkalosis because the two that match are the pH is alkalotic and the CO2 is alkalotic. So it's a respiratory alkalosis. We're not going to talk about compensation, but what's beginning to happen is my bicarb is beginning to compensate because it's gone from 22 to 21. But I don't care about that. I want the two that match. Does that make sense?
Yeah.
Okay. So if I had a PaCO2 of 34 and it's too low, right? How would I make it higher? If you want to vent, lower your respiration and let it build up a little. And if I had one that was too high at like 47, I would increase your respiratory rate to blow it off. Because I don't need that much. You don't really need to know about that, but that's kind of like what we're trying to do with it. Does that make sense?
Our instructor was trying to explain it as if you're driving manual, like basically you want to level off for anybody that drives standard.
You want to drive like manual, what?
I guess she was like, we went over it and she was trying to help us explain it. So she was saying when you're trying to basically bring a person back down to normal, it's almost like driving a standard car where you have to let go of your right foot. So you're letting off the gas. You're like if you're gonna drive,
You're going to adjust between
Yeah.
the shifting and the gas. And that's what you're kind of looking at. Well, which one needs to go higher or lower? But with respirations, it's pretty easy. I can adjust the ventilator and I can breathe you faster and get rid of that PCO2 and bring it down to normal. Or I can breathe you slower and it can build up. Okay? But there will probably be questions on this, which is why we're going over it.
Oh. Questions with an S or with a without an S?
Or questions more for what we should do in.
Questions on the test?
No, that's not what she said.
Oh, what?
Can you repeat that again?
No, I'm gonna, like, I'm trying to.
I'm sorry, I didn't hear the question. What was the question?
No, I was trying to figure out where we have to know the arterial blood gases. Is it more for us to determine, like, if we have to question, what would the nurse do, or more or less which kind of, like?
They're
is it
probably gonna
metabolic
ask you a
acidosis
definition
or-
question, like,
Okay.
these are your numbers, so what do you have? And they'll give you 4 choices. Is it metabolic or respiratory acidosis, metabolic or respiratory alkalosis? That's what they usually like to do, so it's multiple choice, and you pick which one it is.
Okay.
That's probably,
It won't be a
But
scenario.
how about, we don't have to know anything about
It's
the
like melting in
tic-tac-toe,
here.
exactly?
I'm sorry, what?
Is there anything exactly we need to know about the tic-tac-toe method, or?
Well, some people like to do that, so if I'm looking at it, with the two things that match, it's easy to say, oh, I know, no problem, it's respiratory alkalosis.
Okay, so, okay.
It helps you. If it doesn't help you and you don't like it, don't worry about it.
Okay.
But some people love it. They like to use the tic-tac-toe, put it in, say these two match, and I'm all set.
So as long as we know if it's metabolic or respiratory.
Yep, then you're golden. That's fine. That's fine. So now we're up to the nursing interventions. We've got maintaining a patent airway. I need an airway that's open for you, right? We need to suction as needed. We need to administer prescribed oxygen or ventilator therapy because all those are ordered by the doctor, not by us, but he'll order it, or your provider. We need to obtain oxygenation levels and maybe pulse oximetry. They order the ABGs, the pulse oximetry we can usually see. And even on the floor, they have some, you just put on the finger, you walk around and you see how it is. People have seen that in clinical. I want to ensure he has IV access because I said, oh, I want to give him IV drugs and I might need to feed him and I might need to give him IV medications. So that would be good. And he might be dehydrated because he sweats so much, so I'd like IVs. I need to reposition him at least every 2 hours or more often as indicated so that he doesn't get a pressure ulcer and so that his lungs can expand. I'm going to do the passive range of motion exercises to minimize oxygen demands and maintain joint mobility. I'm going to perform respiratory care measures such as chest PT so I can loosen up the secretions and suction them out. I'm going to cluster care activities. Just like with anyone else, when I'm fatigued, I'm not going to do everything at once, okay? His bath, his bed, suctioning him, those things can be done like separately and let him rest a little in between. If he desats, if his oxygen saturations go down, I'm going to give him a rest, okay? I want to make sure he doesn't get a DVT. I want to do meticulous skin care and oral care because I know that antiseptic mouthwash is what really helps to prevent the ventilator-associated pneumonia. I want to provide emotional support because the patient is really anxious with all this going on, and so is the family. You need to know for yourself, is this the part where he gets better? Or is this the part where they say, we want to make him comfort measured only, nothing's working, it's just getting worse and worse, and you know it's going to go downhill from there. So this family is really anxious, and you need to allow them to talk to you. And like I said, talk to them and look at the misconceptions. So if they get chemically induced paralysis, check out what's going on. See what they think they heard, you know? It's really scary. And they need to know that you're going to be with the patient and advocate for them and watch out for them. You're going to provide alternative communication means. So if I have a breathing tube down my throat, can I talk to you? If you hear me talking, there's something wrong. Okay, that's bad. So I need an alphabet board where I could point to certain letters or numbers. Or could I have the most common things I could tell you? Because sometimes I can read your lips and sometimes I have no idea. Did you want to go to the bathroom? Did you want to change the bed? Do you want to change your gown? Do you want something to eat? Do you want a blanket? Are you cold? And they're going, where's my family? And you're like, okay, I missed that one totally. So if they have a few questions they can point to and ask you so they can feel like they can get the message across to you, it really helps. And then we need to wean that ventilator as they order it because we want to make sure that the patient's condition improves and that we don't keep them on too long. So the expected outcomes for this are going to be maintain a patent airway and his oxygen saturations are greater than 92%. I would love that. Maintain hemodynamic stability and adequate cardiac function, so his blood pressure is good. Maintain adequate cardiac output. Develop no signs or symptoms of infection. Now, this is going to be tough if he came in with an infection or he came in with sepsis and stuff like that. I want to make sure there's no more infection or it goes away. Consume required caloric intake, because I know he's needing that to get well. Express feelings of energy and decreased fatigue. So now he's saying, oh, I feel better. You know, I can maybe do something, maybe sit up. Verbalize feelings of anxiety and fear, so they can talk to you. Maintain skin integrity, so they don't break down. And then maintain joint mobility and range of motion, because you saw for 18 or 20 hours if they're there, they're not moving at all, we move for them. The nursing diagnoses are there, that you can read those. I'm not going to read those to you. These are the key points that Kim saw that will probably be on the test, know the difference between hypoxia and hypercapnia, and she's got it all written out. Mechanical ventilation, no non-invasive indications and invasive indications. We're not going to ask you a lot of questions on that, really, but know that we can intubate you if we need to and put you on a mechanical ventilator, and it would be the non-invasive ones are just easier to use on someone. The pressure alarms, what are the 3 alarms?
Mm-hmm.
High, low, and apnea?
Yes.
Okay. What about the nursing care, the VAP prevention? You're gonna love remembering that, okay? The risk factors and causes are on there, and when I look at making up a multiple choice select all question, I need to have something with a lot of choices in it. So guess what? It's gonna be risk factors and causes, maybe signs and symptoms, also called clinical manifestations. Those are where I'm gonna take it, okay? Treatment, pharmacologic management, so know the neuromuscular blockade. The nursing care, we talked about the 5 Ps, what you're gonna do. And then ABG interpretation, because it goes so close with this and it's a good review for you. So we have a
Bless
few
you.
questions, God bless you, on the NCLEX. Yep.
So real quick, so the
Sure.
key points are, beautiful, it's straightforward. But what I got from the review that we had before our exam, not that I expect you or Kim to pretty much repeat your lectures from morning to evening by verbatim, I get that. But I felt that the morning class was getting a lot more from both of you in terms of what would be on the exam versus what we would get. And I just didn't think that was
I don't think so. I think I tend to tell you both the same things, like what I'll say is, this is important, or I'll ask you about it.
They said things that we had never heard.
Like what?
I can't remember exactly what it was, but.
cardiomyopathy diet.
Yeah.
Restricted was one.
We never heard that,
That would be Kim.
and they
Yeah.
knew all about it.
That's what I was just saying, I don't expect
What
you
else?
to
Is there
do-
anything else
I
that?
just remember there's a couple things that like we all started looking at each other, like, what are they talking about? We've never heard it before.
Okay. Usually I pretty much try and stick to this. And the things I'm telling you on here are the things we'll go over. The things we're looking at are things you need that we feel are important. They're probably also on the NCLEX, and you're so close to the NCLEX, and I know you hate to say that, but we're kind of looking at what would help. So I'm sorry, if there's something else you see, come make an appointment, come see us, and we can like go over it.
Well, that's the thing we had never heard before until we were all in the same class.
Room together.
Interesting.
Yeah.
Okay, we'll watch that.
Which was like, what, the day before the exam?
Huh?
Which was a day before the exam, so learning everything that day was kind of hard.
It is close. It is close. You guys are doing a lot. So what we try to do is go with the concepts to make it easier. Like there were more slides. Like you saw for the cardiac, there were like 110 slides. We cut it down to like 35, and we're going with certain things to focus on. So we're trying that for this too.
So for oxygenation, we're just doing ARDS, right? Are we doing ARDS?
Yeah, ARDS is your exemplar. It's your concept.
Okay.
And pretty much you know the other symptoms are going to be the same thing for acute lung infection, right? I'm going to be tachycardic, tachypnea, I'm going to be short of breath. All of those things I'm going to see it. My pulse ox might be too, not too good. But when you put oxygen on me, I get better. So it's just a continuum,
Right.
Does
No,
that
I
make
meant
sense?
no, I meant like as far as just for the oxygenation part. We're for respiratory. It's just ARDS.
We're not gonna go over things like cold symptoms or pharyngitis or anything.
No.
Okay.
So it's
No,
just
they-
ARDS.
They want to stick with, they
Okay.
wanna that's what they've decided, to stick with it as a concept, and you can apply this to other concepts. Okay, so, NCLEX question number 1. The nurse is caring for a patient requiring mechanical ventilation due to ARDS. The nurse understands which of the following are a component of preventing ventilator-associated pneumonia. Select all that apply. So, would you maintain the head of the bed at less than 30 degrees? No. Okay. Would you provide
That's the
oral
correct
hygiene at least every 2 to 4 hours?
Yes.
Nothing else.
Would you provide a daily sedation vacation?
Yes.
Yeah. Because remember, he's on a vent. Would I ensure patient comfort by administering benzodiazepines to prevent VAP? I kind of thought yes, but Kim said no. She goes, it's really not on your list of the bundle, and it wasn't on my bundle list. You'll probably see someone medicated just to sedate them because it's humane, but it's not going to prevent VAP other than to calm them down and let more air in. Pardon?
D or E?
D. Benzos. Yeah. to my mind, you gotta be on a benzo to have the sedation vacation from the benzo.
Right, that's what I was thinking.
But she said, you know, the sedation vacation is part of the VAP bundle. Being on the benzo isn't really part of the VAP bundle. Administer peptic ulcer disease medications as ordered. Yes, so I'm feeling like the doctor, I think that's important, and I'm gonna put that on, so I ordered it. So I'll say yes. And then perform spontaneous breathing trials daily as the patient condition allows per MD order. Yes, okay.
So it's all of them except A?
Not D, not A and not D. She tried to put them up, the answers, I'll try and put them up, they wouldn't let her save, when she tried it from home. Yep. Did you have a question? Yeah.
Where how she said that the benzo wasn't part of that either?
It's not part of the, yeah. That's the one that's kind of equivocal, they're like, yes, do it, don't do it.
That
So-
was a bad question, I guess, right? It's questionable.
No, it's, yeah, I might not choose that, but the VAP bundle, I gotta tell you, every NCLEX question I'm looking at has the VAP bundle on it.
Well,
And that's part of the VAP
well,
bundle.
so, but would the benzo be part of it or not?
Not for preventing pneumonia, for ventilator-associated pneumonia, but sedating you, stopping your sedation
That's the one with the
so that you
pickle.
can start breathing is worthwhile. That
So-
showed people got off earlier.
That's this, so stopping, is that the sedation vacation?
Yes, only for the time period, like you stop the sedation,
Okay.
let them wake up, try and breathe on their own, not on the machine, using their own respiratory muscles.
So what would be the administer benzo? Why was the confusion with the administer benzo?
Because it's something you do to keep the patient comfortable, but it's not part of the VAP bundle. So when you looked at that IHI VAP bundle, yeah. Yeah.
That,
It's gonna be easy. No, it is. Because you know what?
It's number 11.
It's only.
You just passed it.
On that,
On that slide.
Like the,
On the big slide.
freaking patient is not getting
No, on the other one.
oxygen.
Oh, yeah, I'm
The
sorry.
grapes is like.
I'm like melting in here, I'm sorry.
So
If I read it correctly, it's number 11.
You're right, there it is. Okay, I decorated it with the Pico.
So the
So,
sedation vacation.
the things that I would do is the VAP bundle, and this was from the IHI. They said we want you to elevate the head of the bed 30 or 45 degrees. They want to do deep vein thrombosis prophylaxis, because I got you on bed rest, so let's make sure you don't have a DVT. Peptic ulcer disease prophylaxis is recommended currently, right now. Daily sedation vacation. And then, not only am I gonna shut off your sedation, I'm gonna see if you're ready to extubate. So I'm gonna have you try breathing spontaneously on your own, without the machine, using your own respiratory muscles to see if I can get you off sooner. And doing antiseptic solution mouth care every 2 to 4 hours. That's
So-
the bundle. So the benzos aren't on here,
right.
except for the fact that you're gonna stop them for the sedation vacation.
I'm
Yep.
sorry, but can you explain that again, this daily sedation vacation?
The daily sedation vacation is, we were medicating them so they were down and out. And then they go, oh, they can't come off the vent because they can't wake up and we can't try breathing on their own. So then they said, listen, leave the pain medicine on, don't give them sedation, have them try the breathing trial on their own, off the vent. You know, you disconnect the tubing stays in his mouth, he just goes on oxygen, and he does the breathing with his own lungs so that his respiratory muscles get a workout, and see if he's ready. Sometimes you put them on, they break out in a sweat, their heart rate goes up, you're like, oh, they can't tolerate this, go back on. Other guys fly through it and they're like, I think we can take this tube out. So you wanna get the tube out, decided that would help, because if you went on a vent, you can't get ventilator-associated pneumonia.
And then,
And they want their reimbursement. And we want them to get reimbursed so they can pay us.
and the peptic ulcer medication, was that?
Protonics,
Yeah.
um,
What would that
Pepsid.
be, yeah, it's on here, but would that be part of the, to keep you from getting
Yes, it's part of the bundle. It was one of the things that they thought would be wonderful. So the reason I used this first as a Plan, Do, Study, Act was they gave me everything except for the structured oral care, and they said, try this bundle, it'll be great. We tried this bundle and it wasn't great. So then you go back and, well, what's wrong? What should I do now? They were like, okay, all of these things have a good idea behind it, but they're not making the VAP rate go down. When they added the oral antiseptic solution, the VAP rate went down.
So my question is, for the question one, would the peptic ulcer medication be one of the answers? No.
Yes,
I don't know,
it is
but I
one.
understand.
So that will
I
help
understand.
prevent the pneumonia.
Yes, and she kind of wrote it as peptic ulcer disease medication as ordered. The idea is if I change the pH, it's not so acid, when you aspirate, it's not gonna kill your alveoli so much. That was their reasoning. And sometimes people, even if they're intubated, aspirate. Does that make sense? And the reason we're spending time on it is everything I Google for NCLEX, it keeps coming up. Okay, the patient, yeah? Yep.
On the band, it says 30 to 40.
On which one?
On the other hand, see here, you say 8 is not part of the answer.
Say what? I'm sorry.
Maintaining the head of the bed, the 30 degrees.
Oh,
is wrong,
I said
right?
maintain the head of the bed at less than 30. I lied. I wanted 30 to 45.
Oh, okay.
I lied. So I'm saying 30 to 45 because it's called semi-recumbent, but if you go lower than that, we're finding that we don't keep them that way.
Okay.
We turn them, put the head down and turn them. We send them down exams. We put them on a pretty flat stretcher. People come back and they go, oh, I think that's like 30 degrees. They found out we weren't really doing it that accurately, so then all the beds have the little numbers on it now, so you can make sure you get it at the right angle. Yeah.
Okay.
It was tricky.
So,
30 to 45. That one says below 30. We want above 30. Does that was a tricky one.
I hope she asked too.
It was. Okay, so NCLEX question number 2. The nurse is caring for a patient with the following vital signs. Temperature of 101.2 on the temporal artery. Have you done temporal artery temperatures?
Yeah.
Okay.
Yes.
Where are all these temporal artery temperatures located? What hospitals? Who's doing them?
We did when we were in there. We haven't had Carney.
Oh, Carney, okay, I'm like, yeah.
Okay, good. I didn't see them at BNC and I worked there, but some of the ICUs have them. It just depends. If you saw it at Carney, it would be Stewart. You might see it at Norwood.
We have it.
That's what I'm thinking. Yeah,
I couldn't get the damn thing to work.
because they're all the same group. So heart rate's 113, respiratory rate's 36. Is that okay?
No, high.
Blood pressure's 98 over 47.
Low.
Kind of low. SpO2 is my pulse oximeter or my oxygen saturation, 84% on room air. Room air is
Something's wrong
21%.
with this patient.
Okay, so which of the following would be the nurse's first priority? Should I administer a beta blocker for tachycardia?
No.
Should I suction the patient's airway? Should I apply 100% FiO2 by a non-rebreathing dose? Yeah, because it's airway. And should I administer 2 milligrams of morphine IV push for respiratory distress?
That could be it.
It's a great drug, but first I'm going to give you the oxygen.
I'm just kidding, Ginny.
I know. But it is good for the patient. It really is.
Morphine. No, just
Morphine gets rid of some of the fluids, and it sends it out in the periphery, and you can breathe. So if your guy's having a lot of trouble, they love it, because now they can breathe. Okay? It really helps.
Everybody wants morphine.
Actually, thanks to Natasha, you explained that to me. when
It
they
doesn't
were
last
like-
long when I give it IV. So-
They just
They just need a little high, they don't need to be high.
Not a lot, okay.
I needed morphine one time.
Some people don't like it at all.
No, it's like a roller coaster.
I never had morphine.
Yeah.
Wait, would I know if I was given morphine?
So the nurse was caring for a patient who was just intubated, so anesthesia came, respiratory came, they just intubated this person, and they have an endotracheal tube for severe respiratory distress related to ARDS. Which of the following interventions would be the priority of the nurse? Which is she gonna do first? Secure the endotracheal tube to the patient, auscultate breath sounds bilaterally, suction secretions through the endotracheal tube, and then provide oral hygiene status post-intubation. Okay, so I wanna auscultate first and make sure the tube's in the right place. Not that securing it's not bad, but anesthesia's gonna do that for me, or respiratory. Not that oral hygiene's not bad, but that can wait until I make sure it's not in your stomach, okay? And suctioning would be fine, but let's wait and make sure where the tube is. Okay, number 4, your pH is 7.30, your PaCO2 is 48, high or low?
Sorry, what'd you say?
PaCO2 is 48, high or low?
Hi.
Acid or base? Acid. My pH is 7.30, acid or base? Acid. Oh, I got 2 acids right there. PaO2 is 80, it's okay.
That's fine.
Bicarb 25.
That's fine.
Okay, so I have a respiratory 1. Good. All right. Now, I have a pH of 7.50. Acid or base? 7.50 for pH. Alkalotic. PaCO2 is 40. Normal? 35 to 45 is normal?
Yeah.
PaO2, 88. Is that okay? Bicarb is 29.
Hi.
High. So what do I have?
Metabolic. Alkalosis.
Perfect. Good. Very good. That's our last one. Any questions? Is there anything else that?
Not